All right. Hi, everyone. Welcome. Thank you so much for joining. This is another Learn to Return Learning Network event. Today is all about DOH K-12 guidance, which was released less than 48 hours ago. We're joined by Kim Sanchez, the Director of K-12 Education Engagement, and Laura Newman, a Senior Epidemiologist at DOH. So we're going to start with their presentation. Then we'll move into a facilitated Q&A. What I did is I reviewed all of your questions. I identified 39 unique questions. I've shared them with Kim and Laura. They have tailored their presentation to try to answer as many of those questions as possible. Great. Laura, I'll pass it over to you.
Thanks so much, Sarah, and thanks everyone for having us on to talk about Washington State Department of Health guidance. I'm happy to be here with you this morning. I'm Laura Newman. I'm an epidemiologist with the Washington State Department of Health, and I manage our non-healthcare congregate settings team. So for this morning, Kim and I are going to talk about certainly the K-12 school and childcare guidance that was released in the last, I think Sarah said 48 hours, which is correct. But first, I want to give a really quick overview about where we are in terms of COVID trends, both nationally and in Washington State, just to frame the discussion. And I'm going to point out a specific tool and walk you through some CDC numbers that you may be able to use while making decisions during this school year about some COVID-19 prevention tools. So nationally, COVID-19 cases are trending downward. So this is an epi curve since January 2020. So nationally, COVID-19 hospitalizations and deaths have plateaued nationally. There are two epi curves here. The one on the left is weekly hospitalizations. So across the country, we are at just over 3,000 weekly hospitalizations. Down from a peak of 21,000 weekly hospitalizations. That was back in January 15, 2022. There's a curve below that shows the ups and downs of weekly admissions per 100,000 population across the United States. And the different colors indicate different age groups. So it's very small, but this dark purple is ages 70 and above. The figure on the right is the number of COVID deaths in the United States. In the last week. So in the last week, there were more than 2,500 COVID-19 deaths across the country, down from a peak of 23,000 deaths per week in mid-January 2021. There is often talk about variants, COVID-19 variants across the United States and here in Washington State. This is a figure of the different variants. The different colors just indicate variants. The vast majority of them right now circulating in the United States are Omicron, with various lineages. This is a figure of the whole United States and then little pie charts indicating which variants are most prevalent. We often see variants changes starting on the East Coast, which trickle over to the West Coast. You can see that the Omicron variant, this teal, is very prevalent in our Western region and then starting to get a little less so in the East Coast. But many of these are still Omicron lineages. So we'll focus here on Washington State. So the previous figures were all taken from the CDC website, and you can look at the links that I put on the slides above. These are all coming from Washington State. So Washington State does send our case, hospitalization, and death data to CDC, but if you want the most real-time information, we will have it first. And so we have a data dashboard that I've linked below. This takes just a little bit of time to incorporate into CDC because they have to incorporate every state. So this comes right from our Washington State data dashboard. This is an epi curve of the COVID-19 cases per 100,000 population, broken up by age group. The thing that I want to call out is that while we may be at a plateau here in the summer, what happened last year, this is when Omicron really started in late 2021, a very large peak in the winter time. Just want to call out for you this yellow and red line. These are ages 12 through 17 and 18 to 34. Just that COVID-19 cases among K through 12 school age children were higher than any other age group last winter. You can see purple is a little bit hidden behind there as well, but that's ages 5 to 11. I'm not in the business of providing forecasts or looking into a crystal ball for this upcoming winter, but want to flag that this is what was happening last year. Currently in Washington state, COVID-19 hospitalizations and deaths are also plateaued. We, at this point, have an average of 263 COVID-19 hospitalizations per week at this plateau, and an average of 38 COVID-19 deaths per week in Washington state. So this is a figure of vaccination rates broken down by age groups. So starting with 6 months to 4 years of age, all the way on the left, moving towards those 65 and older. I just want to call attention, the take home here is that the percentage of children and adolescents that are vaccinated, oh, and I forgot an S, is less than 40%, and less than 8% of adolescents have received their bivalent boosters. This rate is actually quite low across the state, even though 65 and older, less than 30% have received bivalent boosters. So if you haven't already, get your COVID-19 vaccine. This is the best way that this is a great tool that we can use to prevent serious illness and death from COVID-19. Washington State Department of Health puts out a weekly report describing COVID-19 cases in children and adolescents. The link is below. As part of this report, we break down or organize these case rates into educational service districts. So this is an image pulled from that report, just showing that children in various ESDs have varying rates of COVID-19 at the moment. So these are not necessarily children who are going to school, but they are children represented across the state. So right now, in ESD 101, they have the highest case rate among children and youth, with 140 cases per 100,000 population. I want to give a little bit of an update about influenza in Washington state. We have, I'm just checking something. So we have minimal flu activity in Washington state, although across the whole country, we are seeing an early increase in influenza cases. To date, we have 2 influenza-related deaths, and the most common type of influenza is type A. Something to note is that, so we are very early in the winter season, but this purple line that you're seeing shoot up on the side is RSV. So this is another respiratory virus that impacts especially children under 5. It can be quite severe, and we're seeing just a very high rate of increase of RSV in the state right now. At least on the western side, hospitals in the Seattle and Tacoma area are seeing a huge rate of children coming in with respiratory illness and RSV in particular.
So I'm Kim Sanchez, out of the Office of Strategic Partners at the Washington Department of Health, and I'm the Education Engagement Director supporting K-12 programs as well as early learning and childcare. So in taking a look at the state of where we're at, we're going to kind of take a look at the guidance that just was released. I'm going to pivot back to kind of talk a little bit about some key preventative measures. And so we're going to keep Laura on for this piece to kind of talk about what is a tool that's available to you, again, to be able to help support decision making.
Okay, so something that is a useful tool that we are writing into a lot of our guidance documents, including the schools and childcare guidance documents. It's also in our masking one. It's a useful tool for anyone in the public to be able to use, which is the CDC community levels. So these are indicators that can be used to help make decisions about when to start and pause using certain COVID-19 prevention tools. So this can help make decisions about when you may consider indoor masking or initiating screening testing. So COVID-19 community level is in 3 categories. There's low, medium, and high. And the way that CDC calculates this is based upon national, state, and then pretty hyper-local by county. They take the COVID-19 cases that are new. They incorporate new hospital admissions due to COVID-19 and also staffing capacity for inpatient beds that are being used by COVID-19 patients. So this is not a very early indicator of a flare-up or many outbreaks of COVID-19, but really taking into account multiple indicators to determine what level of COVID-19 is impacting your county. So there's these three levels: low, medium, and high. And you'll see in our guidance that we indicate that when CDC community level is high, or this orange, that is a good time to consider initiating using masking indoors, and also considering screening testing before some higher risk activities. This is something that you can determine on your own. So there's a CDC community level link at the top of this slide, and I'm just calling out two pieces of the website. If you scroll down a little bit, you can choose your state or territory, and then you'll get a graphic of your state. Here's Washington State on the right. So right now, as of this morning, our whole state is considered a CDC community level of low. So right now, per our guidance, we wouldn't be recommending indoor masking or screening testing for high-risk activities.
Thank you, Laura. I really appreciate kind of giving us where we are. I mean, we have an understanding that COVID is with us, and with that understanding, and as I had mentioned when I was with you in the last network event, with the sunsetting of the state of emergency. So what does that mean for schools, and what are you finding in the guidance? So taking a look at the timeline as we did last time, I just want to highlight that again, the guidance came out on the 25th, that the current guidance is still in place through the 31st, and that this guidance is effective November 1st. A key piece is, I know we talked a little bit about structure last time, and a lot of thought, conversation, discussion, and collaboration went into the structure of the document. And in thinking about what have we learned over time, we structured the document to follow the pattern of prevention, response, and then references and recovery. And so when I kind of draw on my educational background as an educational leader and teacher, the way that what I compare this to is thinking about what are those strategies that we universally use. So were we talking about, say, bullying and harassment in a school setting? We'd be talking about those tier 1 interventions. What kinds of things do we do universally? What are the preventative steps we take to minimize, in this case, the spread of respiratory illness, which includes COVID-19? And an important reminder is that this guidance is written for multiple audiences, written for you, for school leaders, for school nurses, as well as for local public health. And as thinking about these multiple partners, is another thought about how this guidance is put together is looking at how are we leveraging our high impact resources. When I think back to the early days of the pandemic, there was a lot of work on all of our parts to try to figure out how do we manage infectious disease and how do we keep kids learning. And so over the course of time, we have developed these partnerships, these ongoing conversations and collective effort towards these ends. And so what you're going to see in this guidance is that the guidance is grounded in science and lived experience. A lot of feedback has been shared from not only local public health, but from key school partners, including school nurses, educational leaders. It's built from lessons learned. What are those things that are reasonable within a school setting so that we can continue to keep kids learning? And it really is thinking about what is our collective responsibility and our collective efforts towards navigating the changing nature of COVID-19, as well as other respiratory illnesses in school. So one thing I want to really highlight in this document, different from the previous iterations, is previously the document described what do you do if you test positive? What does someone do if they're exposed? And so a difference in this document is that it outlines basically what you do in those circumstances, but it also links out to the general public guidance for both testing positive as well as being exposed. And it's important to note that these two documents were updated as well, and they were released and posted last Friday. Additionally, I would point out that the decision tree, I know we had a few questions that were submitted by participants relative to the decision tree. The decision tree remains up on our website. Our teams will move into the place where they will review the decision tree and potentially revise it, or perhaps look at it in comparison to the general public symptom tree, to try to streamline and make things simpler, easier. But at this point in time, we would encourage you to still access it as a very useful tool. And then know that more information will be coming in that relative to the decision tree. So again, when we think about the structure of the document, the document begins with everyday prevention strategies for everyday operations. And again, I want to highlight that really it's a framework for infectious disease mitigation. We are specifically calling out those things that will help minimize transmission in schools of COVID-19, but also be thinking about these best practices as strategies that can be leveraged in other circumstances as well. And knowing that schools and districts have comprehensive safety plans that they're required to have and they build over time, you can almost think about this document as being a living piece of that comprehensive safety plan, as something that is specific to COVID-19, as well as generalizable to other infectious respiratory illness. So this slide that you see before you, it doesn't necessarily follow the structure of the document, but I wanted to kind of highlight thinking about these best practices in terms of the decision and choices that we can choose individually, that we can support and educate around, and the relationships that kind of hinge all those things together. So as you look here, you can see under individual, we absolutely support, validate, and encourage people to access vaccination as one of a key high impact strategy to avoid severe disease relative to COVID-19. And for schools, we know that you work very hard. Our school nurses work very, very hard in terms of getting children broadly up to date in their immunizations. So education, conversation is going to help support this individual piece. Creating cultures where we stay home when sick. This was something we did prior to the pandemic. It became a key piece throughout and continues to be a key high impact strategy. That's true for children, but it's also true for us as adults. I was in a meeting yesterday with school nurses, and we talked about how we have a culture of going to work sick because it's easier to be at work sick than to be gone. And how do we continue to really educate and think about staying home when you're sick? Some of these other strategies that you see are things that we have done, we have always done, we know that they work, and they will continue to work as we include them within a school setting, within a childcare setting. Laura talked a little bit about how to access those CDC levels and maintaining that awareness, because that will help you make those decisions as changes occur in your local context. Maintaining your testing infrastructure is a key high impact strategy. Really appreciate all of the work and effort into that infrastructure, and would encourage you to continue to maintain it so that you can leverage it as needed. I do want to point out two other pieces before moving on, recognizing our time together, but it's critical when we think about what we did prior to the pandemic. When kids come to school sick, when staff come to school sick, it's hard to do the business of school. And so we strongly encourage and urge that we stay home when we're sick. We recognize that sometimes kids come to school, and it's difficult to get a hold of parents, or parents can't come pick them up. But to the best of our ability, we want to encourage sending sick children home. And when we know that they are COVID positive, I do want to point out that for childcare providers and programs, it is required to exclude symptomatic and COVID-19 positive children, staff, and volunteers. And we'll talk a little bit about that a little bit later on in this presentation. Maintaining your notifications. We did that before the pandemic. This becomes still an important piece and is a required piece for childcare providers and programs. But I think one thing, and particularly if you are new to your setting, that relationship that you have either begun to build or have built over the course of the pandemic with your local public health is going to be a critical piece. I think we all recognize across all of our agencies how important these relationships are, how we can leverage each other's strengths to make informed decisions that support our connected priorities, as well as those individual priorities unique to our settings. And acknowledging the fact that staffing does change over time, documenting and sharing those operational best practices will be key and important to be able to leverage them as we continue to respond now and as we move future forward. And so we're going to shift to looking at section 2 of the document in terms of responding to COVID-19 cases and outbreaks. And I'm going to pivot back to Laura for that.
Thanks so much, Kim. In this section 2, we have a lot of recommendations and then indicates which response action items are supported by Washington state statutes. So we have this broken down to responding to COVID-19 cases and then to outbreaks. So as Kim just mentioned, we continue to encourage schools to develop and maintain protocols to ensure that individuals who have COVID-19 isolate away from others and do not attend in-person school or childcare while they are infectious and until they have completed isolation. So in this document, also as Kim mentioned, we have linked to our What to Do If You Test Positive document, which has more guidelines for the general public, and schools can use those to determine how long individuals should be in isolation and away from school and when they're able to return safely. Please note that childcare providers and early learning are required to send ill children home or separate them from other children if there is a risk that the child's illness will spread to others. And students, children, or staff who test positive should follow this guidance document that we've linked below. In terms of responding to the COVID-19 outbreaks, one thing to note is that in this guidance document, we have changed our outbreak definition just to raise the threshold at which it could be a number of cases could be considered a COVID-19 outbreak. So we moved from 3 cases to 5 cases, or 10% to 20% of what we're calling a core group. So this is a classroom, an athletic team, et cetera. Now, I know that with the less of use of contact tracing, certainly within schools, but then also at the local health jurisdiction, it's often difficult to determine if something is an outbreak or if a number of cases are linked in any way. And if there are questions about that, or you want to be able to talk through whether something is considered an outbreak, that's a really great opportunity to reach out to your local public health department. So schools are required, go back really quickly. I'm just going to read those 2 things. Schools are required to cooperate with local health jurisdictions in the investigation of cases and outbreaks, and they're required to notify the local health department about cases and outbreaks. Let's see, if there's just one more note that local public health does have the authority to require implementation of some of these mitigation measures that Kim talked about before, including masking, et cetera, in order to control the spread of disease. So I won't go into this in detail, but if it is helpful for you to be able to see the language that's used as part of the Washington state statutes, we have some screenshots of that here, but certainly you can use this as a reference. So these are responsibilities of child daycare facilities, and responsibility of school. As the state of emergency sunsets in just a few days on October 31st, we are returning to a pre-COVID state where we're falling back on Washington state statutes. Before the pandemic, during the pandemic, and moving forward, local health officers have always been and will continue to be able to require implementation of mitigation measures in schools and childcares, and schools and childcares are required to cooperate with those public health authorities. So I mentioned briefly that our outbreak definition has been updated. This is aligned with something called the Council of State and Territorial Epidemiologists. This is a national organization that sets outbreak definitions and other epidemiology terms for the country. So as I had mentioned, we have updated this to at least 5 cases within a core group or 20% of students, teachers, or staff within the core group. All right, so there is a section in the school and child care guidance that is specific to child cares. The section has largely been maintained from the last iteration. So the presence of the section shouldn't be new. It just does have some additional things to think about for childcares, especially those who have children who are less than 5 years of age. And I do want to just call out that childcare and early learning providers do have requirements around sending home symptomatic individuals or those who have tested positive with COVID. This is the language from the WAC if it's useful for anyone to be able to read through it and point to it. You can read this at your leisure after the conversation. We do define early learning provider in the document and refer to this WAC. So the early learning provider or provider refers to an early learning licensee or designee who works in an early learning program during hours when children are or may be present. This includes center directors, assistant directors, program supervisors, teachers, assistants, aides, and volunteers.
So thank you for going through that, particularly in the childcare settings. The last portion of the document has some key links. One thing or a few things that we want to point out, I previously mentioned the decision trees. Again, we're looking at updating those. They are still on our site. They're mentioned there at the end of the document, but in also thinking about, we know how challenging it is to be responding within a pandemic as well as trying to recover. And so we've highlighted some additional tools from teams within the Department of Health regarding behavioral health. Those resources had been in previous iterations, but I just want to highlight that for your attention as some really incredible resources that can be leveraged, not only for work with children, but also work with staff members as well. And then for all's awareness, it's really important that that you'll see this throughout the document to continue to track what is happening with LNI. In the document, it will link and take you directly to the Labor and Industry website as they are working as well. And having that in your view will be beneficial as employers and as you are making decisions. So I encourage you to track that as well as reach out to LNI with the questions that would be relative to worker safety. Sarah, we are at a place where kind of pivots us back to you for that facilitated Q&A.
Great. Thank you, Kim. Thank you, Laura. A recurring theme in the questions is what's required and what's recommended. How do you want this group to be thinking about required versus recommended?
When I think about requirements and recommendations, I know over the course of the pandemic, this has shifted over time. And Laura did a great job in highlighting the requirements that exist in Washington state statute that existed prior to the pandemic, throughout the pandemic and continue future forward. What I would encourage is the thinking about our mindset around moving future forward. What we have in this document is the best practices that is grounded in science and in anticipated trends, which can help minimize having to take reactive actions in reporting cases, managing outbreaks. So using the preventative strategies, we know if we can work upstream and be preventative in our approach, then it minimizes the additional steps we have to take when outbreaks happen.
That's a really good overview, Kim. And then just to loop back to your question, Sarah, as well, is that in this guidance document, we do indicate all of the best practices that Kim was mentioning, which can really minimize the work that will need to go into fulfilling some of those requirements. So the requirements are bolded. We say when things are required, that's in bold in the document. It's largely concentrated in this section 2. There are a few other requirements that I want to also reiterate, as Kim said, that there are a number of labor and industry requirements around employee safety protections that we link to L&I, and so those will be important to keep track of as well.
Thanks, Laura. So that prompts vaccines for me. What are the vaccine requirements? Should folks be deferring to L&I? Is it in the K-12 guidance? And I'm thinking vaccine requirements for staff, students, and volunteers.
During the state of emergency, which again, the last day of that is on the 31st, there was a requirement for staff in K-12 schools and in educator spaces to be vaccinated. That requirement is going away with the sunsetting of the state of emergency. So that will no longer be a requirement as of November 1st. However, any employer or school has the ability to require vaccination for their staff, but it is not tied to the Washington state of emergency. And then for students, right now, there is no requirement for enrolled students in schools or childcare to have the COVID-19 vaccine. It's not part of the required immunization. To be added, it requires a fairly substantial and public process through the Washington State Board of Health. They did meet over the last fall through February of this year to discuss whether the COVID-19 vaccine should be added to the required list of immunizations, and determined that at this time it will not be added. That could change in the future, but all of that is public information if people want to look into it more through the Washington State Board of Health. So quick answer is no requirements as of November 1st for any students, staff, volunteers.
Thank you, Laura. We got a couple of questions around masking and isolation rooms. Schools use different names for isolation rooms. Some call it the health room, the healthcare room, the protected room. Are they required to continue using isolation spaces?
So this was a requirement in the previous iterations of the guidance documents. Having an isolation space or a separate space to move individuals who may be symptomatic is no longer a requirement, but there is a section on best practices, as you would for any child that is feeling ill or exhibiting some clinical symptoms of illness. They shouldn't be around other children, and if possible and appropriate, should be wearing a mask until they're able to go home. So there is more detail about that in the guidance document as a best practice, but no longer a requirement to have that space.
Thanks, Laura. So it sounds like best practice, not a requirement to use an isolation space, and same with the masking in isolation spaces. It's a best practice, but not a requirement.
For masking, something specific, which is that while the state of emergency is ending in Washington state, and with it, some of these requirements like having an isolation room, what is being maintained is a Secretary of Health mask order. And that does have information on masking requirements specifically for healthcare settings and then correctional settings. There is still masking required in healthcare settings, and we've linked that in the documents. And if that changes, then we'll use our normal means of communication, including with this group, to provide an update.
One last question on this topic, just trying to drive towards clarity. With the masking requirement in a health room per the secretary's masking order, is it required if the individual is seeking care for a non-COVID reason?
Yeah, that's a great question. The setting is, so the health room, the nurse's office, those are considered healthcare spaces at this point in time. And so they're required, whomever is in that space is required to mask. But again, it's linked in our document, and it would be one that we would continue to communicate out.
Thank you, Kim. I'd like to invite Michelle Chung to join. Michelle is the school testing supervisor at DOH. Michelle, we got a couple questions about COVID-19 testing in schools. So a couple of questions for you, if you don't mind me batching them. Can schools still get free testing kits from DOH? Can they continue to use any labor funding they've received through Learn to Return in DOH?
Yeah, thanks, Sarah, for the questions. I'll start addressing the question about the test kits first. And I do want to confirm that yes, schools can continue to order free tests from the school ordering portal that is currently being offered by the Washington State Department of Health. That remains to be a resource to schools throughout the school year. And then talking about the labor support fund that has been used to support funding of in-person staff to support testing in schools, we'll say that yes, the labor support fund is still open, and we are still encouraging districts to continue to apply if this is something that they are interested in.
Thanks, Michelle. As you know, many schools have expired test kits. Can they continue to use expired test kits, and for how long? If not, how should they dispose of those test kits?
So DOH has approved the use of expired test kits as long as the internal quality control that's built into the test kit shows that the test kit is properly working. Like a really good example of what that would mean is if the control line shows up when you put the collected specimen on the cartridge. I know that DOH has developed a document in the past that we can share probably as a link in the chat about a one-pager about the expiration of tests and for further guidance there.
Thanks, Michelle. One last question for you. Can schools test for influenza or strep?
So at this time, the ordering portal that I referenced earlier, it doesn't include tests that test for influenza or strep. However, I think that we would love to hear from folks if you have an interest in having tests made available that allows schools to test for both COVID and influenza at the same time. Share that with us so we understand what the demand looks like there.
Thanks, Michelle. Let's move into reporting test results. Even though testing is not required under the K-12 guidance, we know that many schools are continuing to offer COVID testing to their school community. Kim, Laura, Michelle, what are the reporting requirements for positive tests?
So if a school is doing testing on site or is doing testing for COVID-19, because it is a reportable condition, those test results need to go to a health department. Michelle and others have worked with schools for the last 2 years on expanding a tool called Simple Report, which is a way to report those test results. Additionally, if a school gets information from a parent about a COVID test that was done at home, we're also asking that those at-home test results are sent to the local health jurisdiction directly, and the methods for that vary across the state.
Thank you, Laura. What about the rules for staff and student notifications of exposures?
This used to be a requirement as part of the Washington State Department of Health guidance. This really now falls to regulatory authority by labor and industry. So there is no current requirement around notifying students or families, although certainly it is a best practice to allow families and communities to understand COVID burden in the school. However, labor and industries right now maintains that employers need to notify employees of potential exposure, so that is maintained. But again, because things can change, in this guidance document, you'll see that we just linked to the LNI website that can provide more information about that requirement.
Thanks, Laura. On the topic of notifying families, we did get a couple questions, and I see one in the chat as well. Do we need to change the documentation letters that we send out to families? Are there guidance documents available in any other languages?
So currently, the guidance document that we just released will be released in Spanish, Russian, and Somali to make sure that we have that available for both our school partners as well as our childcare partners. In regards to if we are referring to the briefs, the parent briefs and the staff briefs that we had released or rolled out in August, there is not a plan at this time to revise those. However, I do know that there is some work being done with some of our regional ESDs in terms of providing some additional support in that way for letters to go out, along with some talking points that can help support that effort as well.
Thanks, Kim. Another question that we got related to family engagement. What do we do if families aren't following the recommended isolation periods?
It's a good question, and I also see a question in the chat that says if a student tests positive for COVID, we can't require them to go home. The new guidance just says should. So I'll address both of those. So first to Ashley, schools have full authority to set up protocols for control of infectious disease in their buildings. So that is something that is fully under schools' authority to exclude individuals who have tested positive for COVID. That authority just doesn't sit with the state anymore because of the state of emergency being lifted. To get to the question that you had, Sarah, about what to do if a student isn't or refuses to isolate, or if an individual as part of the school community is refusing to isolate. Isolation at home is the authority to enforce isolation at home for an individual with an infectious condition sits with the local health jurisdiction. So if a school is having difficulty with communicating that to an individual, or somebody is refusing to do it, then that would be a time when they reach out to their local health department for assistance and support.
Thank you, Laura. Laura, you shared the new definition of what is considered an outbreak. Are there any guidelines for closing classrooms during an outbreak?
We do not specify like a cutoff or any details about when to close a classroom when there is an outbreak. Because Washington State is really trying to do everything we can to support as much in-person instruction and reduce the days that students are missing school. Decisions to close classrooms really fall within the school as they're working with local public health. So instances that you may consider along with your local health jurisdiction to close a classroom is if there's enough individuals are sick that it's not possible to run the classroom, there's no adult supervision, or COVID transmission is not able to be curtailed by implementing some of these other mitigation measures, including masking. So we, generally recommend that if there is an outbreak in a classroom, again, working with your local health jurisdiction, who may suggest things like universal indoor masking, screening testing, which means test everyone in the class to try to catch people who have COVID early. So there are a number of steps that can be taken before closing a classroom is necessary. But it is up to the school and local health jurisdiction.
Thank you. Now, I know you both reviewed the isolation and quarantine recommendations. Do you mind if we do another lap clarifying quarantine and isolation requirements and recommendations?
Sure. So I'll start with quarantine. I'll start with the difference between the two. So quarantine is staying away from others when somebody has been exposed to COVID. So if I am a teacher and 4 of my kids or even 1 of my kids has COVID and I spent a significant amount of time with them, I would be considered exposed to COVID. Quarantine is a strategy that would say, since I've been exposed, I would stay away from school and home and away from others for a certain amount of time, and to see if I develop symptoms. It's really a measure to try and stop spread early. It was something that we used a lot during the pandemic, but at this point is no longer a recommended strategy for schools, although it could be considered for childcare. So if someone is exposed, then you can find more information about this in our What to Do If Exposed document that really lays out some steps. The recommendation is that if you know you've been exposed to COVID, that when you're indoors, you wear a mask and then get tested 3 to 5 days after you've been exposed. So there are still some things that we can do if we know that we've been exposed, or if we have an ongoing exposure, for example, at home. Certainly wearing a mask is a really good way to control, we call it source control, to keep COVID from spreading to other individuals. For isolation, I'll pivot to that. We talk about isolation of individuals, so that's staying away from others if you have tested positive for COVID. There are no requirements for isolation of students from schools. I'll talk about it in 2 ways. We can talk about exclusion from school. So that's when a school can say you cannot come to school, and isolation at home, which means staying away from others. So there's no requirements anymore around isolation or excluding children from schools. That is coming from the State Department of Health. But that is something that schools can certainly implement, or that a local health officer can say at any time. So from the state, there's no requirements. L&I does have a requirement that employees are required to isolate away from their place of employment. And again, you can get more information about that when going to the links that we've provided in the guidance document. So in summary, quarantine, not a requirement or really much of a recommendation at the moment. And isolation is not a requirement from the state, but could be from a local health officer or school.
Thank you, Laura. As you know, some schools offer services to children ages 3 to 5, special education required preschool, and transitional kindergarten. Does the school district follow childcare rules or school rules?
It's a good question. I think it may be a question from your licensor. So if you are licensed by DCYF or fall under this definition of childcare or early learning provider as indicated by the Washington State statute, then that facility would need to follow requirements around exclusion of individuals who are symptomatic or who have tested positive for COVID.
I'd additionally add to that if it is a program such as Head Start and other programs similar, it would be advisable to look at your program requirements, because some of the different programs have either more protective requirements or point to the most protective requirements.
Kim, Laura, Michelle, thank you for meeting with this group so quickly after the release of the guidance. For folks on this call, thank you for your time today. I hope you all have a wonderful day, a wonderful week, and we'll see you next time. Thanks, everyone.